Okay. So DKA, it can present with any symptoms like hyperglycemia symptoms or abdominal pain, altered level of consciousness. And when you check the blood sugar, you find it very high. But most importantly, they have metabolic acidosis. This is what confirms the DKA. And also, um, we will do like all the investigations. So we'll check blood glucose. We will do UNE. We'll do ABG, of course. We'll do full blood count, chest X-ray, ECG, blood culture if they have fever, if you are suspecting infection. Yeah. So the causes. Also, we need to exclude the causes like infection, the most common cause. So we'll do urine test and. If especially if they have fever, we need to do urine culture and blood culture. And also we'll do ECG because myocardial infarction could be one of the reasons. And from the history, we know that they don't take enough insulin. So insufficient insulin could be one of the reasons. And yes, this is the most common causes. Treatment, which is the most important in these stations. We have our ABCD approach. We're going to give high flow oxygen. We'll give IV fluid. So the IV fluid will start with normal saline, 0.9% saline, and we will give initially 1,000 of normal saline over 1 hour. So 1,000 over 1 hour, and then 500 ml per hour for the next 2 to 3 hours. So like another 1,000 in the next 2 hours. So we will give 1,000 in the first 1 hour. After that, in the second 2 hours, we'll give another 1,000. So just we are doubling the time, but the same amount, 1,000 ml of normal saline. And what else? Insulin, we're going to give 6 units per hour, which is actually it's 0.1 units per kg. So if the patient 60 kilogram, we will give 6 units. If the patient 70 kilogram, we will give 70 units, and so on. And we're going to keep checking the plasma blood glucose. And when glucose less than 14 millimole per liters, we will reduce the insulin infusion rate to 4 units per hour and replace the saline with 10% dextrose. In my country, we don't reduce the insulin, we just replace with the dextrose. So here is written, we reduce the infusion to 4 units per hour instead of 6, and replace the saline to 10% dextrose. The most important thing to remember, when the glucose less than 14 millimole per liter, you need to replace the normal saline with dextrose, 10% dextrose. Okay, we also need to check for electrolyte imbalance. So we're going to, in specifically the potassium. So total body potassium is low, plasma potassium may be normal or high. So with treatment, potassium enters cells and plasma levels of potassium reduced. Therefore, unless initial potassium levels are more than 5.5 millimole, give 20 millimole per hour of KCl. So we're going to give chloride, potassium chloride, 5.5, 20 millimole, per hour if the potassium levels is less than 5.5 millimole. So the cutoff point is 5.5. When the potassium level is 5.5 or less, we can give 20 millimole of KCl. But if the potassium more than 5.5, we don't need to give potassium. Regarding the potassium, and consider NG tube to reduce gastric dilatation and aspirations, monitor urine output. So whenever we give IV fluid, we need to monitor urine output. Of course, we're going to put catheter first and then to enable us to monitor the urine output. Consider a central venous catheter. It's not necessarily this is senior job, ICU, and blah, blah, blah. Hopefully the patient will not get to this point. Yeah, and if there is infection, of course, we're going to give antibiotics, and also we can give prophylaxis, uh, low molecular weight heparin, anticoagulation.